Thanks, Sharon, for inviting me down today, my other esteemed colleagues. So my goal today is kind of give you guys a high-level overview with regards to PRP and tendons and ligaments. So I have the pleasure of working with several sports teams. So Clark Atlanta, which is a historically black college and university in Atlanta. I work with the Atlanta Dream, Morehouse College, and also Overtime the League, which is a pretty, sorry the word the league is in there, but essentially it's a league for 14 to 20-year-old basketball players. And so kind of like the most famous ones we've had so far is the Thompson's twins, who currently play for Detroit and Houston. So those kids are freak of nature. I didn't really do anything, but it's cool to say that I got a chance to work with them. But nevertheless, let's get things going, okay? So I'll be talking about PRP and tendon ligament issues. Most of my talk is going to be guarding around tendons, because that's where most of the data is at right now. I will dab into some ligament issues as well, but when I try to teach these various courses, I try to give you a really good high-level overview, so when you're speaking to your colleagues and also speaking to your patients, you can also have your clinical experience as well as what the evidence says where we're currently at with regards to these treatments. So I have no conflict of interest yet. Hopefully one day I will, so that I can stop seeing through the patients. All right, cool. So let's get into it. So tendinopathy, okay? So here on the left side, we're looking at what a normal tendon looks like. The normal tendon, when we look at the extracellular matrix, tends to be a lot more dense, a lot more healthy. You have typically type 1 collagen within there. So you have all the healthy cells going on this side. Then once we start to get more in the tendinopathy phase, and now we start to play around with these definitions, right? So the word tendonitis, I truly don't use that unless it's really there. Times I might see that. Maybe in De Quervain's tendinopathitis, you might see in those situations. But for a lot of our patients, by the time they get to us, they're more in the tendinopathic state. Now, when we start to talk about some issues with regards to tendinosis, that's really more, we're talking more imaging characterization as opposed to a true clinical characterization. So just to make sure I get those terms out of the way. All right. So with regards, when you get to more tendinopathy, you go from more type 1 to type 3 collagen. And that's important because you start to lose that nice, dense fibrillar pattern that you have in your tendons, and now you start to get to these more loosely kind of packed areas, and that's where you start to get to more dysfunction, and that's the reason why your patients are coming in to see you, okay? Now, why are we using PRP? Now, I know my other colleagues already done some great talks on it, so I'm not going to overbear you. This is more at home reading at night. If you got some young kids, might have you up in the middle of the night, or if you get bored in clinic. But essentially, things that PRP does, we already kind of talked about that vascularization, which is very important. But we also want to talk about how we're improving sometimes that tendon architecture. You go from that type 3 back to the type 1. Well, sometimes you can have improvement in that density, which hopefully improves overall outcomes. We also talk about some inflammatory processes with regards to tendinopathy as well with regards to PRP. So I have the references here on there, so if you guys get bored, you can always go back and read them. All right, let's get going. So most of my things we're talking about systematic reviews and meta-analysis, because then I have a chance of getting a lot of studies as opposed to reading each one. Obviously, there's flaws with taking this approach, because if you got a bad study, you get a whole bunch of bad studies, you're gonna get bad data. So nevertheless, this is what we have so far. So this is one of the earliest ones we're talking about injection with regards to rotator cuff tendinopathy. This was done by Ming and colleagues. I'm pretty sure this was done back in 2018. But essentially, they show that steroid injections improves in the short term. Okay, so we're talking 3 months or less. Okay, if you have like a patient that has like, hey, I really need something today, that might be the way to go. I don't always go that way, but nevertheless, I always like to leave people options. PRP, however, when we start to look at it, it's going more towards that 3 to 6 months. That's when we start to see the improvements. Why am I making it such a big case? Because folks will say like, well, doc, well, nothing happened in 3 months. And I said, well, a lot of these things, a lot of treatments that we have don't work within 3 months. And so we have to change the overall narrative and treatment paradigm of saying, hey, everything unfortunately is not going to be quick. You didn't get here with me because you started hurting 2 hours ago. You're probably not going to leave here perfect 2 hours from now. And that's okay. But the point is, we start to understand how the science works, so then therefore we can start to alter our treatments. But nevertheless, here's one of the earlier studies. What was one of the flaws I saw in this study was that a lot of PRP studies, we don't know what kind of PRP they had. We don't know leukocyte rich, leukocyte poor. We don't know the actual platelet outcomes. Like, we just don't know going forward. So nevertheless, here we go on trial. Here's from 2019. This one had a couple more studies. So this is 18 level 1 studies, so these are randomized, double-blind and controlled trials that had over 1,100 patients. Once again, PRP has statistically significant improvement in VAS scores and functional outcomes compared to its competitors. Okay, so we're starting to see this trend once again. Okay, Problem, once again, I don't know what kind of PRP they're using. I don't know, to be honest. I don't know what kind of tendon pathology they were treating, to be honest. They say rotator cuff pathology, but it could have been tendinosis, okay? It could have been partial tears. It could have been full thickness. I don't know, so I can't make these real big statements. But what I can say is that there's a trend that can potentially mean that PRP can be helpful in situations. Also, I don't know where they're injecting. They could have been injected in the bursa. They could have been injected into the tendon. These are all questions that I could not fully answer, but nevertheless, there's still data that I can kind of extract, so when I'm having conversations with my patients. So lastly, this is an editorial I kind of said, like, hey guys, we need to kind of take a step back and look at things. What they said is, PRP is useful because for a lot of times people saying, PRP is like this voodoo, you guys don't know what you're doing. No, the data says that it can't be used for some patients. The biggest issue that they saw was that, hey, it tends to work more in a tendinopathic state, maybe not as much in the partial tears, all right? And they also call for the same thing for a lot of us that's been looking at this data for a while, is that please characterize the PRP going forward so that we can really be comparing apples to apples as opposed to apples to bananas. Y'all can sing the rest of the song if you want. All right, for everybody else still asleep. So now we've gone from shoulder, now we're kind of going down to the elbow, okay? So here we have an ultrasound guided injection into the common extensor tendon of the lateral epicondyle. The reason why I wanted to put this image up here, so this is funny, this is an injection that I did when we were back in Culture. So this is from 2016, and you can see the ultrasound machine we were using at the time was not as good as the one I have now. But nevertheless, we can see the needle going directly here into the actual tendon itself, but I won't go into all that right now. One of the earliest studies looking at PRP for lateral cardiomyopathy was done by Mishra and colleagues. That was done back in 2014. It was a randomized control trial. The biggest thing was that they saw was that 25% improvement in baseline of the visual analog score. Means that they had less pain. The other thing was that they also tested it with wrist extension, which is one of the movements that you do when you're trying to see if this person has this common extensor tendon pathology. What they saw that also going up to 24 weeks, that close to 84% improvement compared to the competitor. The competitor in that case was a steroid injection, okay? The next colleague, I've done this talk now at least 3 times and I always butcher her name, so I'm sorry. But I believe it's Alarashkan. They did a systematic review. Dr. Arz, I did that right? I'm kidding. But yeah, it was PRP AVI, which is autologous blood injection, which basically means that they just took your own blood and just stuck it back in with no centrifugation at all, okay? Compared to steroid injections, all right? What they saw that once again, that PRP was more effective than corticosteroid injections, also improved the VAS scores, also the DASH scores, which is also a questionnaire that is used for folks that have upper extremity pain, okay? So, oh, hold on. Wow, that's cool. Cool. So great, you guys got a chance to see the end of my study. Let's see if we can go all the way back. Man, took away all my thunder. So I won't bore you guys too much here, but here's what these 2 studies showed, and this is really the whole reason why I put them here. The first 2 colleagues, they saw that for their PRP injections, they actually did see improvement in their tendon architecture. So a lot of my surgeon colleagues are arguing back to me, it's like, how do you know it's working? Well, here are these 2 studies here. One showing that we did have improvement in architecture, which is the reason why I showed you that first slide. And the second thing was that there were some brave surgeons that said, let's compare how many releases that we're doing once we implemented PRP into our practice. What they saw that was over 4 years since they implemented PRP, they went from doing close to 13 releases to down to 4. So I commend those surgeons because now we're saying like, hey, it actually does make improvement, not only from a basic science standpoint, not only from an image standpoint, but now we're talking about clinical outcomes. So this is data when you sit down and talk to patients, this is exactly what I tell them, hey, the data's out here. Here's how it could potentially apply to you. All right, so we made our way from the upper extremity, so now we're going down to the lower extremity. And here we have greater trochanteric pain syndrome, or gluteal tendinopathy, which a lot of times ends up being that. I very, very rarely see trochanteric bursitis, very rarely. Doesn't mean it doesn't exist, but a lot of folks end up having a degenerative process as opposed to the acute inflammatory state. That being said, this is systematic review. They looked at over 100 studies. They pared it down to 7. That was the randomized control trials. From that, they had 656 patients. What they saw was that PRP was much better than steroid in these situations, okay? But once again, I didn't have the characteristics of PRP, but we started to see a trend going on overall. Second thing I wanted to show you from the studies is something I've been harping on already, is that PRP does take time, okay? So here they had the Harris hip score, which is essentially another questionnaire they give patients to kind of monitor how they're doing following intervention with regards to the hip. What they saw is that around the 12-week mark, PRP started taking over once again. Also with the VAS score that you guys are familiar with now, their VAS started going down significantly. In this case, started almost at 6 weeks, they started going down. So we start to see the trend that PRP does take some time, but if you have the right patient with the right pathology, we could have good outcomes. So next coming up here, this is for patellar tendinopathy. So you gotta remember patellar tendinopathy and with Achilles, they have a peritendon as opposed to the regular tendon. And so I think that might be a reason why we have a difference in outcomes. Nevertheless, I still want to give you guys information. So this is systematic review, and they did a meta-analysis looking at the efficacy for PRP with the patellar tendinopathy. Now, once again, this could have been tendinosis, this could have been partial tears, it could have been a calcific component, but nevertheless, it's here. Okay. They had 8 studies, 5 of them were randomized control trials for over 100 patients. They saw that PRP, sorry Nish, had statistically significant improvement with VAS over shockwave. Now, how much I believe it, I don't know, but it was there. Okay. But they didn't see significant appreciable improvement when compared to other modalities, i.e. high volume injections. How many of you guys are familiar with high volume injections? No? Okay, cool. So essentially high volume injection that sometimes I will utilize for patellar tendon and Achilles tendon is where I take a large volume of normal saline, the dab of steroid, and I actually hydrodissect between the fat pad and the tendon, either the patellar tendon or the Achilles tendon. So that's a modality sometimes I would use for these mid-portion patella and Achilles type of tendinopathies. And that's something they compare in the study. I don't have time to get in that today, but that's another technique that I use for our patients that can't afford some of the fancier things that we do, that I've actually seen some good outcomes.
Just one thing on that, not all shockwave is the same. Is that radial or is it focused? What device you're using? So just a blanket statement in that regard is insufficient.
Yes. Thank you, Anish. So next, coming up once again, you have platelet-rich plasma with regards to chronic Achilles tendinopathy. So once again, long story short, PRP did not do as well in this tendon, and I think it's the overall as well the tendon structure. But once again, we don't have what the PRP characteristics look like. Do I still use PRP in these situations? I do, but I'm also looking at each patient in the way that I'm treating them. Next one coming up here is plantar fasciopathy. And so this is a case where they've actually done a lot of work in this space with regards to PRP, a lot of randomized control trials, a lot of patients. What they showed is that PRP did have significant improvement in VAS with over steroid injections and also with some shockwave, but once again, we don't know which PRP they're using. It's a Dr. Garg's part, we don't know what shockwave they were using, but we did see some trends going in the right direction. PRP did not overperform with other quality metrics in this case. So, you're saying, Dr. Stafford, are you supposed to be like telling me all this great stuff about PRP? But yeah, I try to be balanced. I try to give you the good, but I also try to give you the bad as well, so that your patient can make an informed decision. Lastly, as in most of these PRP studies, a lot of heterogeneity, so something to keep in mind. Now, we're going to switch over from tendons. We're going to talk more about ligaments. Most of the talk I'm going to be talking about ligaments is going to be with regards to UCL. A couple reasons. One, I'm a baseball guy, and two, that's what a lot of the literature is at. Okay? So, here's partial treatment for UCL, and the UCL, the elbow, is that Tommy John ligament that you see in a lot of baseball players. We can also see in other sports as well. This is one of the initial case studies that was done by Augusta. What they did see was that, hey, we did have some positive outcomes with regards to PRP and UCL. Now, there's a whole nother stratosphere where we start to talk about why and how these things work, but just to kind of give you guys just a little bit of flavor that, hey, it can potentially work in this area. Once again, why am I showing these ultrasound guided images? It's important that if we're going to be using these various products, we're getting into where we need it to go. This ultrasound guided image, once again, from our fellowship as well, showing me actually taking the needle, actually going to that proximal UCL. Now, once again, I was trying to compare some other imaging modalities to also using PRP to show what we're doing to not only prove it to our patients, my colleagues, but also myself as well. So this was looking at PRP. This is a case series done for UCL as well. This was done in 25 patients. For all of these patients, they had grade 2 UCL tears, and I'll get to that characterization a little bit later. But basically, they had 2 leukocyte-rich PRP injections. What they stated was that 22 out of those 25 athletes were able to get back to their sport. Okay. The average amount of time was 82 days. Unfortunately, still out of those patients, they still had 3 of them that had to go over to UCL reconstruction, which what they were using at the time. So once again, this could be a useful modality, but you have to have the right patient and right pathology, and I'll get into that a little more in a second. And so the biggest thing that they showed there, the previous study here, you can see the MRI. This is actually a distal UCL tear. This is a arthrogram of the elbow. You can actually start to see the dye actually start to flow out. What they showed was that some of their patients, they did have a reconstitutional ligament. So once again, sometimes we have great outcomes, and when we have great outcomes, a lot of times we troubleshoot. But the point is that this can be useful for a lot of different modalities, but you have to have the right patient. So this is another one. This is actually looking at return to play for PRP for UCL injuries. Here's a retrospective trial. And one of the biggest things is that they start to characterize these various UCL injuries, okay? I'm not gonna get too deep down to that, but I want to give you guys just a little bit of context of why I'm trying to piece these things down. So when I'm actually talking to my athletes and I'm looking at their injuries, I can say, hey, based on what you have going on, I think we can potentially go this route. Here's my clinical experience, here's the data to kind of back it up. So I'm not gonna bog too down that in this conference today, but essentially what we start to see when we have these MRI studies, this is a type 1 tear, which is likely gonna do the best with PRP based on the study. Here we start to get over to this type 2 tear. Type 3 tear, we start to get a full thickness, and type 4, this thing's completely obliterated. But nevertheless, they still injected these various ones. Long story short, A and B did the best. Okay. That's essentially what we have going on here. This last one coming up, it should be with regards to UCL. There we go again. Start doing that again, buddy. All right. We have return to sport for PRP for UCL. 15 studies, over 300 patients. What they saw, they had PRP with physical therapy versus physical therapy alone. They didn't see such a huge difference between using PRP versus just physical therapy. And so once again, we don't know what type of PRP they were using. And also we don't know exactly always where they injected UCL. But what they did see was that proximal injuries with regards to UCL in the elbow tends to be more amenable to non-surgical treatment, including PRP. So that's something where you're counseling your patients as well. It's something to kind of think about. It's not only what kind of injury they have, where is the injury of the ligament and the tendon, and how bad is it? Because that will kind of give you a stratification of kind of, hey, you know what, this is where I think our chances of getting you back to play, and this is potentially how long it might take us to get there. All right, so I know some of my colleagues use it as well. I don't use it as much, but here they're talking about using PRP with regards to lateral ankle sprain. God knows how many folks get that. So they're looking at PRP when it's directed into the ATFL. What they saw was that they did have a pain reduction, and for a lot of times with athletes, they have less pain with lateral ankle sprains. They're able to get back quicker. Now, one of the biggest things I have an issue with the studies is I don't know what their stability looks like. It's one thing to be pain-free and playing. It's one thing to have an unstable ankle because we haven't done proper rehab. And so that's my one knock on the study. But nevertheless, you can say, hey, I might be able to reduce your pain, which may means that you might be able to get back to play quicker. But I don't know how overall the structure, how your ligaments going to look over the long term. Now, here's one that has a little bit more meat on the bone. And so this is looking at PRP for chronic lateral ankle instability. So, you know, you have your athletes, or ourselves, has been spraining our ankles since we've been like 19 years old. You have those imperative strains, and unfortunately, that ligament becomes incompetent. And so you start to have, and one of the biggest questions I ask my patients, like, hey, if you're walking on an uneven surface, do you feel like your ankle is shifting? And typically the ankle is yes. And so if you have sometimes the answer is yes with regards to that, that's when we start to get into that chronic ankle instability. And this is where we start to see a little bit more meat in the bone with regards to PRP injection in this area. Several studies looking at injecting to the ATFL. but also injecting into the tibio-talar joint as well. Why is that important? Because when you start to have this chronic ankle instability, sometimes you might start to have chondral injuries because of the fact that that talus is moving back and forth and just kind of thinking around. What they did see was that you have a reduced pain of regards to using PRP after 3 months. For a lot of these patients, that's a life-changing situation. For those that don't want to undergo a lateral ankle reconstruction. All right, so one of the last things I want to show is, this is a study that was done by my colleague Greg Lurie. He's one of the team docs for the Atlanta Braves. And he actually put out a case series with 3 high-level athletes had a PRP injection and ended up having significantly ulnar dysfunction following the injection. The biggest reason why I brought this up, because these folks were not injected using ultrasound with regards to the UCL. Why is that important? Because you can inject under fluoro and you'll miss your vascularity area, but you don't know exactly what that ulnar nerve is. Sometimes that ulnar nerve might start to move when position you have the elbow in. And so when we're doing these various procedures, you want to try to have some kind of live imaging to make sure that, one, you're putting your stuff where you want it, but then 2, you're trying to avoid situations like this where you have complications that could be avoided. And lastly, Dr. Wall already kind of mentioned this, but Bill Berrigan, he was one of our previous fellows, he put out a great paper that talks about how platelet dose and how it can affect that outcomes with various pathologies with regards to PRP. So if you take nothing else from this, please make sure to read this paper. It has a lot of good data, and they're going to have some more work coming out soon. So take-home points. I would say we got the green light for these situations. I think we have enough data now, even though we didn't have the greatest characterization of PRP. There's too much evidence now, suggests too much evidence and very limited complications to not use any situation with regards to tennis elbow, degraded trochanteric pain syndrome, and also plantar fasciopathy, okay? Here's some of the ones I might have pause for. It's like, hey, I do have some good evidence, but it also depends on what type of situation we're dealing with. Particularly rotator cuff issues, you can have bursal-sided tears, particular-sided tears, partial thickness tears, full thickness tears. You have to know exactly what you're dealing with before you start going there. Same thing with UCL. Is it proximal or is it distal? Is it a full thickness or partial thickness? These are all very important questions before I say, hey, we got the green light. Here's when we start to get into a little bit of yellow. Now, we do have some promising data for chronic ankle instability. We got some okay data for ankle sprains. For patellar tendinopathy, so far, we just haven't had the greatest of data. And it could be that we're going after the wrong structure with regards to that. So that's kind of a yellow, okay? Yeah, now we're kind of getting yellow to red. So for Achilles, it's funny, I'm currently doing a systematic review looking at PRP for Achilles tendinopathy. And although the PRP, once again, is not characterized, study after study, we're not seeing a big improvement between PRP and other modalities. There could be the reason why, because the type of structure Achilles is, and there's other things that I use in order to help folks out with that. But I won't say completely no, but we just have to be cautious when we're recommending that. And that's all I got for you today. Thank you.